present to you a case. And I can tell you this case is the first patient that I saw. So this was when I was a resident back at Penn State. Hershey was actually, I guess, the first case diagnosed there. So that would have been back in about 2011. And this was a 19-year-old woman. She had no relevant past medical history. And mom came in telling us that she had about a 1-week illness that seemed like a virus. She had had 2 days of vomiting, diarrhea, some decreased sensation in her fingertips, which sort of, I think we attributed perhaps to, electrolyte imbalance from the vomiting. But then she progressed to have emotional lability and actually had called her mom at work to say that she thought the HVAC system wasn't working in the house because there was a persistent humming, which we later realized was an auditory hallucination. But clearly by day 5, something was obviously seriously wrong. She had dysarthria, expressive aphasia, confusion, and paresthesias that were really bothersome in all of her fingers. So they brought her into the hospital. By family history, there was a brother with epilepsy, and her father did die at a fairly young age in his 50s of colon cancer. Social history-wise, she had just really finished up high school recently, was working at a dishwasher in a local restaurant, just using some recreational marijuana, but was not a smoker or regular user of alcohol. So on her exam, from the notes I took this, it was an expressive and receptive aphasia, some inattention, disorganization, fluctuating mental status. I remember clearly, like this was yesterday, she was sitting in the room, just sort of staring off, and would occasionally answer a question, usually with a much longer lag than one would anticipate. But, sort of really maybe a psychiatric sort of a feel about things, as if she weren't cooperating, because she would sometimes answer questions and other times seem to really just not attend to any of the examiners. So psychiatry was involved early on. And of course, you wouldn't be surprised to know they were using terms like a catatonia and things like that. I think it's important here to stop and say, okay, well, how poorly was she doing? And one measure we sort of are all familiar with, borrowed from our stroke colleagues, is a modified Rankin. So if you would take her at a moment in time, she was a modified Rankin of 4, right? She was not in the ICU. She was not intubated, but she was really, over a 24-hour period, unable to attend to her own bodily needs. Yes, occasionally she would get up and walk and sort of seem to be heading toward the restroom, but would never put everything together 100%. So a modified Rankin of 4 in a patient on the floor, not in the ICU, just to sort of put this in a conceptual framework. And that's important when we're going to talk about the trial later. So she had 3 LPs over 2 weeks. And actually by the 3rd LP, it had normalized on its own without a significant intervention, certainly no immunotherapy or anything. The suspicion up front was really strong for herpes encephalitis, and continues to be when these patients present often. During the course of those 2 weeks, she did begin to develop what we later appreciated to be vivid, frightening hallucinations when she was able to communicate. And I'm always sure to mention this because we need to be aware these patients frequently attack staff. And so if you're admitting one and you're working them up for NMDA receptor encephalitis, please warn your staff from the get-go. 3 out of our last 3 patients attacked staff. And it's a very common thing because these hallucinations are really unlike any we're familiar with in neurology. Certainly our psychiatric colleagues are much more in tune to this, but they are vivid and horrific. Fortunately, the patients generally don't remember any of them when they recover. Her EEG was just really slowing, consistent with an encephalopathy, some asymmetry with left greater than right focal slowing. But this is not unusual. We often don't capture an epileptiform discharge, especially early in the course. Her MRI was interpreted as normal. With the advantage of retrospective review, I would argue that there was some subtle left medial temporal hyperintensity, but again, frequently MRIs will be interpreted in normal in at least half of these patients up front. And in a good percentage, even when you look at them in retrospect, they are really quite normal at presentation. Ultimately, we obtained a CT scan in her course. And another caveat, this was interpreted as a functional cyst. I think that's sort of the standard sort of thought by body imaging radiologists in young women, that if you see something like this, it's a functional cyst, you would re-image at some point later in the menstrual cycle and expect it to shrink. So this is something that I've encountered a lot over the years now, where we really have to push harder on this imaging and go to different imaging modalities to demonstrate in appropriate individuals with high suspicion that these are not functional cysts, in order to convince our colleagues that a surgical intervention is appropriate. So it was a mature teratoma ultimately, and it was removed. Now, remember, this is 2011. So at that time, the only place in the country you could test in the US, anyway, for NMDA receptor encephalitis on a commercial basis was ARUP, which I would later find out is actually here in Utah. I had no idea at the time. But nonetheless, they weren't running this assay every day like they are now. And so it took a long time from sending this out, from having the theory that this might be what was going on. And in fact, she was discharged by the time the result came back. So we convinced the surgeons to take out a teratoma, and we initiated plasma exchange, still with no diagnosis confirmed. She then had her first convulsive seizure after that first plasma exchange. Ultimately, fortunately, though, began to gradually improve with the exchanges, and probably attributable to removing the sort of nidus of the immune system attack, the teratoma in her case. Like a good sort of 19-year-old, once she was able, she refused any additional intervention that I wanted. I was corresponding with Joseph Downow at the time via email and really asking him for advice. And, we were talking about rituximab, we were talking about an anti-seizure medication. She didn't want any of it. So I learned a lot from this patient, as you might imagine. Dermoid cysts appearing similar to functional cysts, and the importance of advocating for review. MRI brains often being normal or so subtle as really not to be appreciated as abnormal in these patients. The EEG often not as helpful as I want it to be, non-specific. At that time, no one had really gained any familiarity with Delta brush, so that was not really routinely reported either, which we now know is a characteristic pattern in some of these patients. And then what she really taught me was not all of these patients need long-term immunotherapy. Now, if she had presented to pretty much any hospital in the country now, boy, we would have probably thrown the kitchen sink at her, right? But this comes up even more in the course of the pandemic. Was that the right thing to do, right? And we really don't know the answer to that. This was also a mild case of NMDA receptor encephalitis, yet I did follow her over the course of completing my residency there, and her cognitive recovery for things we might consider subtle, but are really quite important to a 19-year-old just starting her independent life and career. Her recovery was prolonged. And then I finally also, the hallucinations are very distressing. She was the first patient I saw them in, but certainly not the worst. And hers were so sort of vivid and dramatic that we actually had to call in social work. The things she was saying, which ultimately turned out to be true, require investigation, all sorts of things. So be aware of this, and be aware to warn and protect your staff, especially so the young males, if for no other reason, they tend to be stronger. So what did this also sort of lead to as I had more time to think about it? Well, I'm a clinician scientist by training, and this was terribly bothersome to me because there were so many questions and really no answers. What would have been the ideal treatment? How long should that treatment go on? How did I prognosticate? Like, how was there data in there that would have helped me prognosticate? What was her chance of relapse? Why did this happen to her? Some sort of susceptibility or her genetics. And of course, this nagging observation that, not all these patients do need long-term immunotherapy, and really planted the seed in my mind for treating the patient and not myself. For any of you who have treated these patients when they're in the ICU and they have persistent, nonstop disturbing movements, oral facial dyskinesias, dystonic posturing, it's very hard to look at them. And so I'm reminded of sort of one of our neurology colleagues' advice saying, don't just do something, stand there. It is very hard in our sort of nature to want to do an intervention, just to do something, to watch these patients, but maybe sometimes a little more equipoise is needed. So this is sort of where I hope we're on a trajectory from going from madness to understanding. Certainly, I don't think it's a stretch to imagine what happened to these NMDA patients in the past, what still happens in this era. Still, patients come to us after having been involuntarily committed to psychiatric wards, for long periods of time until they have their first undeniable, say, seizure or clearly neurologic symptom. So what do we do right now? Well, the standard of care that we operate off right now, first things first, we try to arrest antibody production. So that involves removing the tumor if it's present, because that's obviously pouring gasoline on the fire. The immune system continues to see the neural elements in those tumors. This for women is frequently a teratoma or dermoid cyst, same thing, really just different flavors of terminology. And for our young men tends to be a teratoma or seminoma or a combination of both. In some of our older NMDA patients, this can be a small cell lung cancer or other more classic malignancy that we would look for in aging patients. And then once we take out a tumor, if it's present, we sort of immediately initiate first line immunosuppressive therapy. And this can be high dose steroids, IVIG, plasma exchange, some combination of above. And then we sort of say, okay, we've arrested the antibody production. Now let's try to get rid of the existing antibodies that are in the circulation. And we do this with the off-label use of traditionally rituximab and cyclophosphamide and some other agents. Again, the kitchen sink starts to come into play here as more monoclonal antibodies become sort of available for off-label use. But the idea there, arrest antibody production, then clear the antibodies in circulation. And then this last piece is the piece where we really have to be diligent or these patients fall off the radar, right? It's a ton of fun to treat these patients up front in some cases, because you really get a dramatic response. You seem to sort of be plucking them back from certain death and stabilizing them. But it's really discharge from ICU through the next 2 years where they really need our expertise. And this is where the patients tend not to be followed as aggressively and where we really have some room to go. But certainly while we're still in the ICU, patients with this condition still die. Despite all of our tools available, they still die a certain percentage of the time. And some of those deaths seem, on review, really unavoidable. The disease has just run its course and has been unresponsive. Some of those are due to autonomic instability. So we need to watch these patients closely. They develop arrhythmias. They can, sort of plummet blood pressure, shoot them in either direction, have complications that go with that. Iatrogenic infections acquired in our hospital. And then, coagulopathies, all the things that go with critical illness. We really have to be really in tune to for these patients. But with all of that, yes, we still have a small percentage of patients that do pass away, but overall we're doing okay. This is from the review that I mentioned in Lancet Neurology from 2013 of 501 patients at that time, retrospective, a huge majority had substantial recovery, right? So we're doing okay. And that's defined as a modified Rankin back down to 1 or 2. So a good outcome when you think back to what happened to these patients, 30, 50, 75 years ago. The problem is, good, meaning you didn't die and maybe you're back to independent living, is still not great, right? And so this is sort of, what one of the impetus behind the trial, right? And it all depends how you look at things. And this quote, I think, really hits home. Discovery consists of looking at the same thing as everyone else, thinking something different. And I think what a lot of us have been thinking in this field is good is really not good enough for these young patients. So, where do we have room to go? Well, in a lot of places, right? The motor outcome's pretty good. Most of these patients end up ambulatory, but cognitively, here's a study from 2015 where he looked at 40 NMDA receptor encephalitis patients, evaluated a full, 27 months after their hospitalization. They still had worse verbal, visuospatial, memory performance versus controls, and their hippocampal volumes were clearly reduced in patients compared to controls. Here's another study. We're looking at children, so arguably greater disability accumulation over the lifetime. The whole brain, gray matter, hippocampal, and basoganglia volumes were reduced in the children recovering from NMDA receptor encephalitis. And furthermore, they had failure of age expected brain growth in recovery. When we look too at the things that maybe aren't as dramatic, but are significant for quality of life, this figure is from a paper that really just came out a couple months ago. This is all comers with an autoimmune encephalitis, not just NMDA receptor encephalitis, but they have mood disorders, sleep disorders, fatigue. Many of them can't go back to driving because of ongoing concerns with seizures, or they're not able to have the energy or the cognitive sort of functioning to return to work or school full time. They may be on these long-term immunotherapies or complex regimens of immunotherapies that affect, their reproductive outcomes. And we haven't even talked about the care partners here. The care partners for these patients are profoundly traumatized and have a huge burden on them. So when we suggest that the outcomes are good, we want to be very, very careful to use that term because we may undermine our efforts to make things better, and we have a long way to go here. Having said that, again, past 15 years, we've now gone to thousands of patients and thousands of publications. We have multiple organizations supporting patients and supporting the clinicians who specialize in taking care of these patients. You all know there's a New York Times bestselling novel, Brain on Fire, and of course the movie, which was based on that novel. So here we are. The time is now perfect to do this trial, to come up with some better outcomes, treatments, and data, frankly, for this patient population. So the Extinguished trial for NMDA receptor encephalitis, you don't have to look too hard to figure out that's a play on the book, Brain on Fire. It's a phase 2b, double-blind, randomized controlled trial to evaluate the activity and safety of inebilizumab in this condition. And it's a phase 2b trial, so there's a huge component of creating a biorepository to assess for biomarkers, both present and future. It will be set up such that investigators from around the world can apply for access to those samples for relevant research projects. And so what are we looking at primarily here? Well, we're going to use the modified Rankin score. So when you go back, and I told you that patient sitting on the floor, stable from an autonomic perspective, not requiring ICU care, had that modified Rankin of 4, these patients are ill even in the best, most mild cases. So we're going to look at that modified Rankin score because we don't yet have really well validated prospective measures for autoimmune encephalitis specifically, but before you ask, we are including those in these trials to validate them. So for this outcome, we're going to look at the difference in the modified Rankin score at 16 weeks in participants with NMDA receptor encephalitis treated with first-line immunotherapy. So everybody can have their choice of 2 different regimens of first-line immunotherapy. Everyone gets that, a standard of care. And then after receiving that, they're randomized to either inebilizumab or a matching placebo. And then at day 21, everyone, again, both placebo and the inebilizumab arm, will receive 3 days of IVIG. And then at 16 weeks, we'll measure that modified Rankin score to see change from baseline. Patients to be enrolled in this trial do need to be ill. So we are not enrolling a modified Rankin score of 1 or 2, but that's going to be a small minority of patients with this condition anyway, but keep that in the back of your mind. It needs to be a score of 3 or higher. I hope I sort of conveyed to you that it's not hard to achieve 3 or higher. Obviously, we'll also be looking at the safety of inebilizumab in this condition. You're probably all aware that inebilizumab has an FDA indication for neuromyelitis optica and has been studied by our pharmaceutical partner in a large number of other conditions that they didn't necessarily pursue through the FDA approval. It's a humanized, affinity optimized monoclonal antibody that binds to B-cell specific surface antigen CD19, right? So this is similar to rituximab that binds to CD20, but this actually depletes CD19 positive B cells as well. So it's a broader spectrum of B cells earlier in the cell lineage that's getting a hold of sort of plasmablasts and plasma cells as well. So theoretically, we would hope for a more robust and earlier effect. Without going into excruciating detail, but I'm always happy to do it later, we have a ton of secondary and exploratory endpoints. This is looking with a huge focus on cognitive changes, also the biomarkers we mentioned, but quality of life, healthcare utilization. These patients are tremendously expensive. They tend to be uninsured or underinsured because many of them are young, sort of, teenagers or college age or just getting started. And then we'll also look at clinical pharmacology. So here are the trial sites, University of Cincinnati, front and center there in the middle. I'm putting this up there so you can get a sense of who is your closest geographic neighbor. So perhaps Michigan, maybe Iowa to the west, kind of just looking over this, but you can see you're a bit of an island here. So it's going to be absolutely critical to reach out to your colleagues via your referral patterns, your referral networks, general teleneurology, to encourage early and immediate referral of suspected NMDA patients. And depending when the paperwork's completed at your site, our target to begin enrolling is January 2022. This will be individual based on how quickly each site moves to get their final IRB approval and regulatory documents done. We do have 2 European sites. Rotterdam is where Martin Titcheler is located, and Barcelona is where Joseph Dalmau is located, and they will be enrolling patients at those sites. They will come on board later than the US sites due to all the sort of EU, US kind of regulatory burden. So just sort of an overview, backing up a step, the general autoimmune encephalitis treatment approach that we take. We treat this as an emergency. We use empiric first-line immunotherapy. And in my clinical practice, I do not await antibody confirmation, even though I am spoiled. I can get it much faster than anywhere else in the country because I have ARUP 100 yards from my clinic. I still start immediately if the patient meets criteria for what at that moment in time would be sort of an antibody unknown or antibody negative autoimmune encephalitis. And we hope that all of our enrolling sites will do the same. And so we have provided 2 treatment pathways to use while screening and awaiting those results. So that's a key thing, though. You have to use one of those 2 standard pathways that have sort of been, approved, by consensus by sort of the world experts. But it's important, again, not to sort of veer off and do all kind of things that wouldn't be considered standard of care, and to educate your potential referring sites of that. My practice tends to be for all of these patients before I touch them to save biosamples. I would encourage all the sites to do that. Many of our sites already do because you're research sites. But either there's one of 2 mechanisms to do this. Either if you already have an approved research biorepository, you certainly could consent them on that outside of the study. But the other way to do this that's not on a research basis is to talk to your lab, whether that be your local hospital lab or your send out, and say, look, I need to make sure that you are clinically holding these samples for at least 2 to 3 weeks. And that's sort of done routinely for us. We've worked that out locally as well. Our samples are all held. CSF is always held for 2 weeks for us. And likewise, you can put in a miscellaneous order and saying, hold, I'm going to draw, this many red tops or purple tops, hold them clinically. And then you can go ahead, sort of full steam, giving your immunotherapy and knowing in the back of your mind that if you guessed wrong, if this is some atypical infection or something else, you have samples available to test and prove that later. So for this trial, it is important to point out we are accepting the patients with the underlying malignancies, teratomas, seminomas, you name it. They are eligible for inclusion in this study, and we're interested in including them in this study to help us understand better how their outcomes compare to people who don't have a detectable malignancy. There is a 24-hour on-call hotline. I'm actually just finalizing the phone number today for what that hotline will be. It's going to be staffed here at the University of Utah by me, some of my colleagues, and we will actually provide this number as well to ordering clinicians upon return of a positive NMDA lab result. Both ARUP and Mayo Clinical Labs have already volunteered to do this for us free of charge in the interests of advancing the science behind this condition. So that right there takes care of greater than 50% of the testing in the country for this. I won't tell you the other 2 labs who might want to charge money for this. And so we're still in negotiation, but we at least get half the country right there where the ordering clinician will be notified in the comment section of the result that this trial exists, and they will have access to the hotline, and they can call and we could say, oh, you're in Ohio, please look at going here, right? So 3 things that are easy to do now. I just hinted at this. Standardize your protocol in-house for first-line immunotherapy. This is not a bad idea in general for just good clinical care of any suspected autoimmune encephalitis patient, right? What is allowed for the trial specifically is high-dose corticosteroids for a minimum of 3 days. This usually ends up being in the neurology world, 1 gram of IV methylpred, and either IVIG or plasma exchange. What we don't want is the kitchen sink, which is when people do IVIG and then exchange it out, or vice versa. So it's steroids and IVIG or steroids and plasma exchange. And this is usually determined culturally, locally, whatever the hospital's most comfortable with. Certainly we know the pediatric hospitals tend to go to IVIG. Some outlying referring hospitals may not have access to plasma exchange around the clock. So, either or, sort of the experts in the field, none of us really feel we have strong evidence. We just all have personal preference for which one we do. So if you can get that established and begin to talk to the referring institutions as well, like, let's agree to do this because it's sort of expert consensus regardless, but also we won't automatically disqualify anyone for the trial. As I alluded to, standardize a policy to save cerebral spinal fluid for all suspected cases of autoimmune encephalitis. When I am doing a tap on any adult, provided they have good flow and it's safe, I always obtain at least 30 cc's of cerebral spinal fluid. We turn over our entire volume of CSF 3 times a day. So this is not missed by the patients. And I will do that because there's nothing worse, right? We all know this, than going back to the patient 48 hours later when you only got 10 cc's of CSF and saying, I have to re-tap you, right? That does not make our patients or their family and friends very happy. So I always try to go in for a large, at least, it's not even a large volume tap, but at least 30 cc's up front. And then I freeze it, right? I put in an order in the chart with that, with my cell count, protein, oligoclonal bands, my antibody testing. I also put it in an order to the lab, a miscellaneous order saying, save all extra CSF. I know they do it for 2 weeks, but I'm a little compulsive and I put in the order telling them to do it anyway. So this is a great thing to get in place as well. And again, this is just going to serve your patients better. It avoids multiple lumbar punctures for patients who, outside of the trial setting. And then the other thing is to standardize the routine screening labs that every patient with a suspected encephalitis should probably have regardless. Serum chemistries, hematologies, obviously, but quantiferon assessment, hepatitis B, C, HIV, these are all things we need to have the results of before you would consider giving an immunotherapy to a prospective patient. Likewise, total baseline immunoglobulins, I think increasingly more and more of us in the field do collect these regardless, to know where we're starting from and to make sure we're not missing an underlying undiagnosed immunodeficiency. Obviously, before you would start some of these medications, you want to ensure that you're not missing a pregnancy and or a malignancy. So flow cytometry there. And for the purposes of this trial, I think it's pretty clear based on all the literature and the expertise in our field that this diagnosis is made off of cerebrospinal fluid testing. So an NMDA serum antibody result is not sufficient to enroll in this trial. We need cerebrospinal fluid positive antibodies for NMDA testing. So that's most of it. I think we kind of went through that, hopefully in a bit of a whirlwind, so we have some time to talk. Obviously, I have a ton of people to thank. This slide doesn't even come close to covering it. But this has been a huge multidisciplinary international effort of all the Neuronext sites, and I'm so excited that we're even to this point.
Great. Thank you so much, Stacey, for the great talk and for all the work that you're doing. So I was going to start with one question about you already kind of mentioned, but is there a specific recommendation about how we can reach out to other colleagues when you mentioned about the telemedicine, any other way that we can inform other colleagues about making the referral to us? Go ahead.
It's going to be very site specific. So I can tell you, we're doing things at the national level, including, we have the Autoimmune Encephalitis Alliance on. I have to schedule my next phone call with them. And then there's the NMDA receptor group out of Canada. So we're collaborating with both of those groups to do some marketing. Social media is obviously going to be a component of this as well. So I have in the sort of, I made a huge sort of 10-page sort of marketing plan that's been approved by the Central IRB that will begin enacting. But locally, it's much more of a challenge. And so I'm doing this too for the University of Utah right now. So I've started, I'm trying to just all hands on deck, right? And anything I can do that's cost neutral, right? No one has budgeting to drop 50 grand on marketing, right? So within the department, they're going to put an announcement in the newsletter that goes out to our patients and clinician sort of referral network. That's coming out this fall. So they're going to put a snippet in there. We're going to probably, I'm going to have one of our marketing people write an article on the trial, and that gets disseminated a whole bunch of places. Do more of the University of Utah, leverage that social media sort of network as opposed to just sort of say mine. What other thing, you know, so like here, Jen Majersic is our stroke division chief. So, and then we have a different general teleneurology director. I'm going to reach out to both of them. And I've already given grand rounds to the University of Utah, to my department, but I'm going to reach out to them about sort of more formally letting our referring teleneurology partners know about this trial. And obviously sort of partnering with, yes, you have access to us 24 hours a day for teleneurology, but here's the hotline as well for more information. So then you have access sort of to me and the trial staff, all of these little pieces. It's just, you know, I'm trying to, anything we can do that you know, is already existing and we can just pile on their platform, doing some smaller outreach stuff too, through our sort of director of nursing. You know, it's really challenging for this trial because these patients present not through normal neurology routes, right? They come into the ED, they come in as a transfer from psychiatry. So we really need to broaden who we're reaching out to. I don't know, what ideas do you guys have?
Right. Great. So we were going to have this type of meeting, reaching out to some of the colleagues. As a matter of fact, we have other neuroimmunologists that they work in another center. They have a special interest in the autoimmune encephalitis. We already reaching out like a kind of personal, at the personal level. We also use for spreading the information. We use an app. Our research team recently started using an app called High Enroll. So it's a web-based app, smart app that they don't need any logging or any information to have an account. Basically, we just have like a synopsis about the brief inclusion exclusion criteria. We share those information with the colleagues, and they can actually refer a patient directly to us if they need to reach out to me or the research coordinator. It has all the information. So we're working on that, but any other material or education that you can help us with, I really appreciate it.
Yeah. Also, the other thing I got approved was sort of, you know, again, just to reinforce those relationships is the ability to, we'll like knowing if you had a referral from a referring hospital and who that clinician is, to sort of just give them a little swag and send them a thank you, that kind of thing too. And then I'm also giving talks. So it's a bit maybe more straightforward out west here, but Intermountain Healthcare System is the other major player out here. So I'm talking to their group, just giving a grand rounds there, or occasionally, sort of getting 10 minutes here, 5 minutes there, and some division meetings of some of the smaller partner hospitals. A lot of just really grassroots. It has to be, for a trial like this, and you hope that it sort of trickles through to the ER and psychiatry.
Sure, exactly. So we have some question in the chat box. I was going to ask Kat if she can help me to go over some of those questions.
Yeah, absolutely. So Dr. Ravindra Arya has asked, what % of MRI negative epilepsy PTs without classic limbic symptoms do have autoimmune encephalitis? Is this incidence sufficient that we should send an autoimmune panel, perform an LP in all PTs with MRI negative epilepsy, except those with a recognized epilepsy syndrome?
Yeah, great question. I think I'll preface it with this. In autoimmune neurology, we never have an algorithmic answer that's a one size fits all, like, yeah, do it in this percent. Because one, it's a moving target. Two, we don't have all the studies yet to give the precise answers. I'll tell you though, there are certain red flags that make me suspect an autoimmune epilepsy. Multi-drug resistance for one. And as you implied in your question, no suspicious, no prior stroke, no history meningitis or encephalitis, no head injury, nothing, right? No family history. And boom, you have an adult come in with a new onset severe epilepsy. Multifocality, of course, is always a red flag, but really just no obvious inciting factor always notches up autoimmune on the differential. If I'm on to my second, anti-seizure medicine, and that notches it up the differential. And then really a family history sometimes can be helpful of just general systemic and other autoimmunity, sort of a milieu, if you will. Makes my suspicion a little higher. So at that point, I might move to obtaining spinal fluid. You have to be careful there too. Certainly there are some reports, maybe a little bit older now in the epilepsy literature, talking about abnormalities just in patients who are seizing subclinically or otherwise. And so I might do the spinal tap. The EEG is informative, and I lean very heavily on the epilepsy expertise here. Like, are there any features here that are unusual? The EEG lets me down actually a lot with many of these patients because they have deep structure seizures. And so my epilepsy colleagues say, yeah, a little slowing, but like, stop obsessing. This is not a seizure, right? But it can be if it's a deep structure, and I've only done cortical electrodes. So it's really a gestalt. Honestly, I've asked this to some of the epilepsy colleagues who send someone over, like, okay, what made you send this one? Because they're usually spot on. And it has to do with drug resistance, atypical appearances on the EEG, multifocality. Some of them are going for surgical evals, and they determine, multifocality. It's a general clinical gestalt, I think, based on how they presented all of it. There's no one answer. I wish there was, man, it would make things so much easier.
Okay, and then Dr. David Carroll has asked a similar question. As a psychiatrist, I wonder how many AE cases we may be missing. What would be your recommendation for the indications for performing an LP in a patient with primarily psychiatric symptoms?
Oh, that's a great question. What I didn't get into in that case I presented was that it was actually the psychiatry liaison who was involved in that young woman's care. The whole reason I got involved, I was not the resident on service, was because I was sitting in the resident workroom, and my resident colleagues were just whining and why will psychiatry not take this patient on their service? They are blocking, she's stable. They keep saying it's medical. It was the psychiatry liaison, right? Who was saying, no. This is not primary psych. This is a patient who does not have the history, who does, again, not have the milieu. There was no depression. There was no family history, and so there actually is a paper. It came out in the last year that Dalmau was on looking at this. I think our psychiatry colleagues in general are very in tune to the possibility of autoimmune encephalitis. And so I doubt that too many are being missed. And if they are being missed, it's only for a short period of time, because what happens is they develop a classic neurologic symptom. So if they were sent to you in a day program or in the inpatient setting, once you get them and you're seeing them for a couple of days, you go, wait, something's not right here. Why are they staring off into space? Or they just have a frank generalized seizure or dysautonomia, sort of start sweating and kind of passing out. And so the psychiatrist, again, appropriately go medical, address it, and send them to the ER or direct transfer to neurology. So I really don't think a ton are being missed. Maybe in some other types of encephalitis, which would be sort of a different kind of talk, like LGI1 encephalitis can present sort of in a much more cognitive psychiatric kind of way without going on to frank neurologic stuff. So I should probably, I'll look up the paper and send it to you, but Dalmau did a great job, because in the history of NMDA receptor encephalitis and the basic science research, one question that came up was IgA antibodies against NMDA. And I think he pretty clearly now has said, we cannot use them. They're unreliable. But that became a question because some schizophrenia patients, some otherwise sort of primary psychiatric, we always have these artificial boundaries, right, had those. And so he sort of dispels that bit and then talks about really from a neurologist's point of view, the criteria that should make you think of NMDA receptor encephalitis. And I'm not going to do it justice, so I'll send it to you. It just came out this year. because he basically, this is a huge question. Our psychiatry colleagues are going, I don't want to be the one missing this, just like us in neurology. And so he addressed that. But yeah, in the first few days to weeks, certainly I think any of us could miss it, especially if they're the ones that don't get the movements or just sort of staring off and a bit catatonic.
All right, we're getting a little low on time, so this may be the last question. Goldsla has asked, is there a window for onset of clinical SX to first line RX?
Really so this is where, if there's a question, we have the hotline. The real sort of exclusion that's going to knock patients out, in my expectation, is just prior treatment, right? But in terms of determining onset of clinical symptoms, right, this can be a little fuzzy. I just had a patient a few months ago who came in with fulminant symptoms, a seizure, a generalized seizure. But as we follow him along, this young man probably was diagnosed inappropriately for any number of reasons we could get into, with a developmental delay beginning 5 years prior. So he was, in all likelihood, one of those rare ones that was subacutely just simmering along, and then boom, within a month of us meeting him, had a generalized seizure and came to attention. So I don't think we would necessarily exclude someone like that, but these are sort of the finer points where that's why we have the hotline, like just to make sure, okay, was there any prior immunotherapy? Was there something else going on? We will be excluding the herpes encephalitis prior to NMDA ones. So again, another thing that would probably come up on a hotline phone call, like, could there have been a herpes encephalitis prior to the NMDA receptor encephalitis? We have to exclude those. So in terms of clinical symptoms, because it's such a gray area, I think if there's any question, we would have you call, but the sort of short answer is probably no. It's just you'll get excluded if you had some treatments, and if you otherwise have other traditional exclusionary criteria. You may want to consider CSF flow cytometry. Yeah, we do check flow cytometry we have 3 CSF draws, and we do check it on these patients. And then the biomarkers, everybody's got a favorite biomarker. So a lot of what we're doing there is just collecting, and that'll be the biorepository afterward, where sort of people make proposals in terms of what they want to check.
One of the considerations what I meant by the window before first line treatment, you may have somebody that's in an encephalopathic state for a month, and then and you may then have a lot of people that are treated more quickly and within a week. And I think there's going to be a differential in a different response in terms of probably how those people respond.
Yeah, we haven't seen that yet. That's part of this study, right? That'll be something we look at in the post hoc analysis. And certainly in my clinical experience, I've had ones where we took a really detailed history, and boy, that was a high functioning physician up until a week before, and were caught super early and treated super early, and bam, they did terribly. And the converse. So part of, again, getting at what you're pointing out is the biomarkers hopefully will help us, that maybe the titers, all of these things we're going to look at sort of after the fact, and perhaps will give us more information on how to prognosticate. But we certainly still want that encephalopathic person. If they haven't had treatment.
Yeah, actually, it might give you some more information, because if, for instance, someone comes in with what you suspect might be autoimmune encephalitis, doesn't get treated or recognized for a month, even with first line therapy, that may give you some indications of how effective those therapies are in helping to prevent sequelae down the road. So I think that maybe it'll help you in being able to sort out. There'll be cohorts that you'll be able to sort out, perhaps, that will be able to tell you, okay, treating as soon as you notice that there's an encephalopathic process going on and it's confirmed to be NMDA, those people do much better as compared to people that you wait a month and before you made the diagnosis.
Yeah.
I mean, there are just some cohorts that I think will come out of that.
Yeah. So, but yeah, and I'm excited, right? We don't know. I can't prognosticate now. And I'm sick and tired of not being able to tell patients like the best treatment or how they're going to do. So hopefully, but yeah, absolutely. We anticipate many of these patients will come to us. And so long as they haven't received immunotherapy or just one of the 2 regimens in the sort of screening period, if you will, we're going to take them.
Do you think that we're gonna able to kind of take a look back at the end of the study as like a subgroup analysis to see the clinical outcome based on the initial presentation? Because obviously they might have different presentation, and if you have the same kind of outcome measure, it might not be kind of the same way. Is that a consideration? Do you see any problem with that?
I mean, I think that's what we're hoping is that all of our sites and other investigators, even outside the network who hear about it, are going to propose these sorts of, you collected this data, let's look at it in this way, let's do that. Right? We have a couple of ideas, but we don't, there are so many smart people who, that's the whole point of the biorepository and it being NIH so that people can then get access to do these subgroup kind of analyses after the fact. I hope, it's 116 total people enrolled. So when we start subgrouping out, the numbers will get small quickly. But even if there's a signal, that'll be worth knowing. I don't know.
I'm excited. I want to continue. I was gonna see if you have time. I was gonna ask Kat, is that okay if we continue with a couple of other questions, or we need to stop?
Fine with me.
I don't know. It depends on whether or not other people have meetings scheduled, because this is a communal Zoom account amongst the CCTST. So let me.
If it disappears, we'll know what happened.
Yeah,
exactly.
Basically, if we get kicked off, that's what's happened. But I can check in 1 second.
I have one other comment, and this goes to Aram too. Cincinnati has been a center that really pioneered stroke outreach and TPA in the late 80s and mid 80s. So they developed the concept of the umbrella kind of access where you have one central spoke and you have a bunch of other spokes out into outlying areas to try to recruit people. And I think that the tele visits are extremely helpful. I think that may be one of the ways that we can incorporate as many people as we can, in addition to whatever's at the main hospital. But I think that there might need to be someone that's available to field calls from outlying hospitals, for instance, in patients that may have a situation like that. So I think education of those outlying hospitals and perhaps having someone that's available on a rotating schedule and perhaps for fielding those kinds of calls to determine whether or not the patients may be adequate for transfer, because then we'll be able to I think probably get more patients.
Yeah, and hopefully it's a 2-directional thing. You can, if you're overwhelmed, give them the hotline and we'll do some of the legwork. And likewise, some people may get that notice with their lab result, call us and we say, oh, actually, you're going to want to talk to Cincinnati, right? And sort of put in touch with, whoever your PI is.